Thankful to the organizers for inviting me today to speak on this safety and efficacy of Pralsetinib in RET fusion positive non-small cell lung cancer. This is a phase 1/2 study, the ARROW trial. So we heard about RET fusion, that this is the RET fusion positive tumors are 1 to 2% of non-small cell lung cancer. It was called as BLU 667. This RET inhibitor, Pralsetinib, is a highly selective, highly potent small molecule inhibitor. It works not only on the mutated rearranged but even wild type RET. And it has activity against what we call as V804, which is a very common gatekeeper mutation that confers resistance to multi-TKI. And we heard that this has a very good CNS penetration, which I'll show you in my subsequent slides. From the ARROW trial, that was the phase 1/2 trial, the dose confirmed was 40 milligram once daily. So that's an advantage, they say, that once a day dosing in Pralsetinib compared to Selpercatinib. So this is a very classical eligibility criteria: 18 years of age, unresectable, locally advanced metastatic solid tumors, pathologically or genetically documented RET fusion with a good performance status 0 to 2. They had taken patients with 0 to 2, but after protocol amendment in 2019, they took only with performance status 0 to 1. Patients with active CNS disease were excluded. So RET fusion testing was done locally by IHC, NGS, circulating tumor DNA, FISH, all the techniques I could read in this. The protocol amendment was done in July 2019 in this ARROW trial, where earlier they had taken up patients who were treatment naive but platinum ineligible. From 2019, irrespective of platinum eligibility, patients were taken up. So they were taken up as patients who have been pre-treated. So assessment was done. 400 milligram was the dose, and till disease progression, intolerance, consent withdrawal, or investigator's decision, Pralsetinib was continued. Dose reductions were allowed due to adverse events, but below 100 milligram per day, or if there was a gap of more than 28 days, the patient was excluded from the trial. The co-primary endpoints were the primary, as you can see, overall response rate, that was complete response, partial response by the blinded independent committee review, and the safety were the two primary endpoints. The secondary endpoint was duration of response, clinical benefit rate, PFS, overall survival, and as you heard in the previous talk, correlation with different RET genetic partners. And of course, efficacy depending on the different genetic alterations. This was a very large study which started with 528 patients, RET altered tumors, but of which only 281 patients, which is our patients of interest, that had RET fusion positive NSCLCs. 77 patients were treatment naive, whereas double the patients had received prior either platinum or non-platinum based treatment. This is the same thing which is I told you, but what I want to show you that there were 75 treatment naive patients, and 158 had received prior treatment, of which they have divided again into prior platinum and prior non-platinum treatment. So now coming to results of this trial, in results in the RET fusion positive, let us see with treatment naive and prior treatment. In treatment naive, the overall response rates were 72%, disease control rate was phenomenal, 91%, duration of response has not been reached, and clinical benefit rate was 80% with Pralsetinib once 400 milligrams single dose. Now, according to the RET fusion partner also, they have shown, which I'll show in my subsequent slide, and with those who have prior treatment received, if it was a prior platinum, you see the response rates have gone down to 59%, whereas if it was a non-platinum, the response rates are similar to treatment naive. And this is the PFS. It's 6 months, if you can see, the treatment naive and prior treatment are nearly the same. 6 months or at 12 months also, and at 12 months, 53 to 57% had a very good PFS, as you can see. This is according to the RET partner, and those who had received prior treatment, as you can see the waterfall plot, excellent. Here, there are only few patients who did not respond, who were pre-treated. This is a PFS again, which we can see in patients who had received treatment naive patients and prior platinum. the PFS is not very different if you see from the chart. So to discuss, for the discussion of this topic, the tumor shrinkage was observed in all accessible treatment neo patients. In treatment neo, there was a response rate of 72%, which is comparable to, as you can see, with other oncogenic targeted therapies, as we see with osimertinib, in ALK positive, we heard alectinib, brigatinib, lorlatinib, and entectinib. Means they are very similar, approximately 72% which we got. And this had a very good intracranial response rates of 70%, because patients with active CNS metastases were not taken, but patients with CNS disease were taken. And there was a response rates of 70%, and the response lasted for 10.5 months with Pralsetinib. It is now in the European Union, RET positive NSCLC, it is first line, whereas in second line, it has been approved in RET altered thyroid cancer. And as we heard from our previous speakers, there are studies going on both these, I told you, are phase 1 or 2 studies, but phase 3 studies are going on, where they are comparing Pralsetinib with standard of care and Serpasitinib with the standard of care, that is chemotherapy, immunotherapy. Thank you very much.